we have Stefan Kali, who's going to talk to us about the restraint reduction work at and reducing restrictions of all types at CQC. We have Hayley Moore, who's at CQC, who is leading on the closed cultures work. Then we have Alexis Quinn talking about her lived experience of restraint and also why it should be reduced in social care. We then have the importance of advocacy in preventing and challenging closed cultures with Gail Petty from NDTi. And then last but by no means least, Lemia McEwen, who's from Kent County Council, who's going to talk about their work they've done following the Hesley review, because they had some young people who were in the Hesley services and they've taken various actions as a result of that. So without further ado, I'm going to hand over to Stefan and the first slides from CQC.
Thanks, Lily. Thanks for the introduction and good morning, everyone. Good morning, colleagues. It's really good to see you. So I'm Stefan. I'm the Interim Deputy Director at CQC for people with a learning disability and autistic people. And I'm joined by my colleague, Hayley Moore, who's the Deputy Director for Safeguarding Inclusive Cultures. So in our session, we want to talk about our cross-sector policy position on reducing restrictive practice, and in the context of this session, what we can all do to help reduce that. And then in the second part of the session, Hayley will talk to you more about closed cultures. So if I could have the next slide, please. So why do we need a new policy position? Why did we need it? So I'm going to mention here Out of Sight, full title Out of Sight Who Cares, which we first published at the end of 2020 and provided a progress report in March 2022. And those reports really looked at, as it says here, the journey through the system to seek understanding and the experience of autistic people and people with a learning disability. And the policy position that we published really speaks about the devastating impact that we know restrictive practice can have on people and the trauma it can cause. And that is something we also heard from our expert advisory group for autistic people and people with a learning disability, who we met with earlier this year to talk about our priority areas, and one of those is restrictive practices. And this policy position was a direct outcome of those conversations when people very clearly told us you need to have a clear, united position on restrictive practices across CQC. We needed that clarity, and that's what led to the position. So can I have the next slide, please? So our new position, we've repeatedly called for providers and other partners to act immediately to reduce the use of restrictive practice and to ensure they provide person-centered trauma-informed care always. So that much bigger focus on proactive person-centered care, that preventative care, that good working together. And that needs to be done together. And all of us need to address those issues head on and develop a clearer, stronger position on the use of restrictive practice, which we have done through our policy position. And that builds on our new responsibilities to assess local authorities and healthcare providers together. It really talks about that joined up working, that system-wide working, and actually not seeing the event of the use of restrictive practice in isolation, but actually people's journeys leading up to that and what could have been learned, what could have been done differently as well. We'll apply across all areas of our regulation. And as a result, we expect all providers to know what restrictive practice looks like. So a real point of that position is that raising awareness of all the different forms of restrictive practices, not just the very obvious ones, also the subtle ones. And for all of us to work together to reduce the use of restrictive practice in all settings. So what does it say? Next slide, please. It talks about the harm that restrictive practices can cause and that they should be used absolutely by exception in line with human rights, legally, ethically. It talks about the fact that we, of course, expect care for people to be always person-centered in any setting. Restrictive practice can occur anywhere that people receive care and support, and all of those settings in which people do receive that care, we expect them to be person-centered care. We need there to be positive cultures, relational support, and trust between people and staff. And that really relies on really strong leadership as well and good collaboration between partners. As we've said in many of our reports we published over the last 2 years, there needs to be much greater listening to and understanding of people to understand how people communicate their needs, emotions, or distress, to always start with that as a starting point to actually understanding where people are coming from and how to support people more proactively, more preventatively. And the focus needs to shift to one that respects all people's rights, provides skilled, trauma-informed practice, and supports and promotes recovery. And that learning together is really important as part of that. And as it says here, that debrief element, that learning from events, what could have gone differently leading up to this point is really important to stop it from happening again. Next slide, please. So I just want to highlight 5 key areas of our expectations for ourselves, providers, partners, and people. And of course, all of you in this room today. And they are around people's experience, importance of leadership and learning culture, engagement in conversations, workforce, and the environment. So when we talk about people's experience on the next slide, we want to hear from people. We want to hear and have people's views, voices, the voices and experience of those close to them. And that can be in many different forms. We have give feedback on care, where people and their loved ones, advocates, carers can give feedback on experiences of care, whether they are good or bad. We can have that through conversations with experts' experience or inspectors and assessors on inspections. We continue to co-produce through our regulation. I've mentioned the expert advisory group, so really having that voice of people and those close to people at the heart of everything that we do. And it's really important that we do hear that continuously. And of course, for you also, a role is to really encourage that speaking up as well. So on the next slide, we're talking about the importance of leadership and learning culture, that we expect leaders to lead and maintain a culture of learning within their organizations. And of course, that we expect leaders to promote person-centered care and support to promote quality of life and future well-being. And a question for you here is, are you fostering reflection and learning in your own organization or organizations? And then those that you commission with as well. On the next slide, we talk about the engagement and conversation. That meaningful engagement with the right people at the right time to make a difference is really important. So we're speaking to you today to have those conversations, of course. And we want to keep seeking and listening the views and experiences of leaders to help us guide and support leaders to engage with us. That learning from good practice is really important as part of this. Where are things going really well and sharing more of that. And we want to promote that better oversight of restrictive practice at board level. Who keeps track of restrictive practices and that commitment to reduce them? On the next slide, area number 4 is around workforce. What support is there for the workforce? How can settings attract people and staff with hearts and minds in the right place, and then support them well to have that competence, and the skills to support people in a really good person-centered and preventative way? Are there enough opportunities for staff to reflect on practice through debriefs, through regular ongoing conversations, to promote physical and mental well-being for the people that they support, but also in themselves, because a well-engaged and well workforce can build that trust and support the well-being of people in the services. And then lastly, talking about the environment. And that's not just the physical environment, of course, it's all aspects of environment. It's the bricks and mortar, the physical building, but also people around us and what's happening around us as well. And that can really impact on how we live, how we recover. It influences our mental well-being. So if we talk a little bit more about other aspects of the environment, here we want to talk about the more subtle forms of restrictive practice on the next slide. So the extreme forms, the sort of quite obvious ones, might be well known. But like I said, in the policy position, we really want to raise awareness as well. And there are subtle forms of restrictive practice, such as keeping a walking frame out of reach, keeping people in specific areas, making people use bibs or feeding cups, or denying people access to visitors or food due to lack of staff and time. As it says there, it might make things quicker and easier for staff to manage people, but it's not the person-centered trauma-informed care that we expect to see. It does perhaps not reflect that wanting to seek and understand how people or what people are communicating, what need, what emotion, or even distress. And if we move to the next slide finally, we also want to talk about blanket policies. They're another form of restrictive practice, and they could look like stopping people from using the kitchen, setting bedtimes, bedrooms being locked at certain times of the day, remote CCTV monitoring. So they are blanket because they're regardless of individual needs or making care and support bespoke to what people actually can do and are able to do. So we encourage providers to challenge the use of blanket practices, and of course you in this context too, to ensure that they're not unintentionally restricting people's liberty and human rights. So coming on to the next slide. It's really good to be here to talk to you today because our position is clear, but we need to all work together to make this happen. We'll continue to raise awareness through our sharing of examples and good practice and through our always on approach when we speak at events, when we engage with partners. Across CQC, we're rolling out learning that we have co-producers built and Restraint Reduction Network to make sure that our own teams have got the right skills and knowledge to identify restrictive cultures and to help improve our regulation. All of our learning and guidance around restrictive practices will be incorporated into our single assessment framework, which we're currently rolling out. And my team is one of many teams across CQC who've got that real specialism. So there's our senior specialists, and they can support teams across the organization to get this right. And next slide, please. So just a call to action there that, of course, reducing restrictive practices is one of our priority areas at CQC, but it's everyone's responsibility. And we all can and must do better to eliminate the inappropriate use of restrictive practice in health and social care. And I will hand you over to Hayley.
Okay, so I'm just going to talk a little bit about closed cultures, and that really does have that link into restrictive practices Stefan's just been talking about. So first of all, what brought us here in terms of CQC as a regulator? And unfortunately, as we all know, there's a really long history of organisational abuse and harm taking place within services. And I think people with learning disabilities and autistic people, have really had some very difficult experience over time. And we have seen too many occasions where people are not getting access to the right care and are experiencing real harm within services. Whilst there have been a number of instances, it was events at Walton Hall that led to us as the regulator undertaking and standing up a programme of work that we term closed cultures. And we had two quite critical reports, the Noble report and the report by Professor Glynis Murphy following Walton Hall, that really highlighted certain things that we needed to look at and raise awareness of as a regulator. We have also, as Stefan has mentioned, had the Out of Sight Who Cares review, which is focused on the use of restrictive practices, such as restraint, seclusion and segregation in early 2020. And we've got the progress report, which unfortunately is showing there is a huge amount still to do to deliver on those recommendations, a number of which we haven't seen suitable progress on. But this work is so critical really for all of us around seeing a transformation in services and about making changes for the benefit of all of the people who use them. So what do we mean by a closed culture, which can occur in any service? Today we're talking specifically about services for people with a learning disability and autistic people, but I will stress, this really can happen in any health or social care service. but it is a poor culture that can lead to harm, including human rights breaches such as abuse. And in these services, people are more likely to be at risk of deliberate or unintentional harm. And if I could probably sum it up, services are higher risk where people don't have an adequate voice, that they find it harder to be able to represent themselves. And that can often be because of structural arrangements. Stefan's mentioned, the environment, but there's so many different things that we can place around people that can make it harder for them to have a voice and put them at higher risk of harm. So we see certain features, for example, people being unable to leave of their own accord, living services, such as supported living services, any service where one-to-one care is provided. And of course, out in the community, we're unfortunately seeing people actually with very high levels, hitting perhaps 4-to-1 care. So actually, it's not just about, sort of like in-person sort of institutional type settings as we might think of. So if I just move on, in terms of early warning signs of closed cultures, it's where we see people actually starting to experience poor care, including unlawful restrictions. And these can include, as Stefan's talked about, restraint, long-term segregation and prolonged seclusion. And often, we see lots of issues around care not being person-centred. We can see issues with language in terms of how people are written about. But actually, people are actually experiencing harmful care at this point. We also see signs around weak leadership and management. Often in these services, staff aren't encouraged to raise concerns or speak up. And there's often staff being poorly treated as well, and not having adequate supervision or training or support. And we often see as well a lack of external oversight. So services that are restricting visiting, that don't enable external professionals to come in, that are closed off from that additional scrutiny, that can be quite problematic also. Just in terms of recent learning from the Safeguarding Adult Review that's now been fully published, it was delayed because of the prosecutions that were taking place. There are a number of national recommendations that are really important for us to look at. And I just wanted to acknowledge really that as the regulator, we do have a role to think about how we can work more closely in partnership. I've put this one key recommendation up, which is saying about the importance of us working more closely with local authorities to actually look at safeguarding arrangements within high-risk inpatient settings, for example. But to touch about culture more broadly, we know culture doesn't have a universally accepted definition, and it can be quite contextual and subjective. And here are some descriptions we can hear about culture more broadly. So we can hear that it's the everyday actions of every individual, or the way things are done around here, or the pattern of shared basic assumptions, or what happens when nobody is looking. And I think it's really important to stress that, as individuals, in teams, in our workplaces, how we work with people, we are the people that build the culture, that surround us. I wanted to reference two quite recent literature reviews we've commissioned at CQC, one on improvement cultures and one on safety cultures. They are worth having a look at. It's nothing new because they are literature reviews, but it does pull a lot of material together. And within that, I'll also just reference the concept of a subculture, which I think is quite important in how we think about things, because culture isn't a static thing. Within a service, we can often see different cultures within different groups of people. So that might be as simple as differences in a care home between the staff on the night shift and the staff on the day shift. And that is definitely worth thinking about in terms of that. A couple of things from our rapid literature review on safety cultures. So in terms of that, we've ended up using the definition from NHS England about what a good patient safety culture is. But there are some key things that come out in terms of all of that. So we have, for example, the behaviours and relationships of staff. We have open communication, the importance of psychological safety. So this, for example, is everybody's safety in being able to have a voice and to be able to make mistakes and to raise things safely without being treated differently because of it. we have organisational practice, and we have the absolutely critical point of involving people who use services. And this is more than just involving people in very much a lip service type of way. It's about true collaboration and working with people in service design and delivery in co-production. And finally, I just wanted to mention why speaking up within regulation matters so much to us. There's three different, critical reports listed here: Winterbourne View, Staffordshire, and Walton Hall. And within all of those, whistleblowing was a key component in how the concerns came to light. And I wanted to highlight really, again, why it is so important that, people are listened to when they are brave enough to actually raise their voices and to tell us that something might not be quite how it seems. And just to touch on our listening, learning, responding to concerns review that we published in March this year, where we as a regulator have held the mirror up to look at our own practice and culture and seen that we needed to take steps to learn and improve. And this is very much part of recognising that wherever we work, we all have to build safe cultures where people can have a voice, and we need to listen to each other. And that actually, in tackling all of this, it's about us all taking that responsibility to be aware, to be alert, and to be willing to speak up, because it's really important that we never walk past poor care, and we don't, avoid listening to people when they are trying, to reach out and tell us something, really quite important. So, just ending, with this, quote at the end, we do know that we've still got a whole lot to do to ensure that people are getting the right support at the right time. And we do have some resources there on that slide, but I do know they're going to be shared afterwards. Thank you.
I'd now like to bring in Gail Petty, who's going to talk about the importance of independent advocacy in preventing and challenging closed cultures. Okay, next slide, please, Jensen.
Thanks, Hilary, and thanks, Jensen, and great to be with you all today. And Jensen, could you pop us along to the next slide as well? Thank you. So I'm Gail. I lead the advocacy programme at the National Development Team for Inclusion, and many of you will know we don't deliver any advocacy, but we do care deeply about people having access to the very best advocacy that they can. And as Hayley talked about earlier, having an adequate voice is absolutely a key part of ensuring that we're aware of and mindful of and kind of combating those closed cultures. So some of the bits and pieces of work that we do, we've done some work around strengthening the role of advocacy, making safeguarding personal. We operate the Advocacy Quality Performance Mark, which is a quality assurance mechanism for advocacy organisations, which we're just in the process of updating. And we're updating that following our recent review of advocacy for people with a learning disability and autistic people who are inpatients in mental health settings. And that's primarily because we found during that review, so that report was published in October this year, at the end of October. I encourage you to have a read. But that review found a number of problematic areas in the way that advocacy is both commissioned, delivered and experienced by people who draw on the service, which is impacting on the efficacy of advocacy, particularly in relation to closed cultures. And next slide, please. So I thought it was worth taking a moment just to reflect on the kind of growth of our advocacy services within the country. So advocacy is a relatively young profession. Our first advocacy services kind of emerged in the late 70s, early 80s, and they began in closed cultures. They were designed specifically as a mechanism to begin to open up the closed cultures that we were recognising, both in long stay hospital settings for people with a learning disability and within mental health hospitals. And so we've had kind of a dual journey, I guess, in the development of advocacy. So within those long stay hospitals, we began the development of citizen advocacy. So where advocates stood shoulder to shoulder alongside individuals, kind of questioning approaches, trying to understand and challenge when people's human rights were being breached in those settings. And then within mental health services, we saw this emergence of peer advocacy and the beginnings of a kind of patient involvement and patient improvement experiences with self-advocates, primarily from Nottingham in the early days, kind of developing those approaches. So the emergence of advocacy services within our health and social care within England and Wales very much began in closed cultures. That's where we started, and was always about, next slide please, has always been about a safeguard, about ensuring people's voices are heard, about ensuring people's needs are understood and recognised, that people's preferences and preferred ways of living and being are recognised and understood and essential to the way that people are cared for and supported. Absolutely about people's rights. So advocacy, when we think about the definition of advocacy, I haven't popped it in the slides, but it goes, so the Advocacy Charter, which is the kind of commonly used document to define advocacy within England. The Charter definition says something like advocacy is taking action to support people to say what they want, access services they need, and uphold their rights. And then there's something also about equality and inclusion and achieving social justice. But it's absolutely about recognising people's uniqueness, and it's about ensuring people's safety. Next slide, please. So we know, don't we, that we've got a range of different types of advocacy, and over the years our statutory advocacy requirements and the statutory advocacy that we need to make available to people kind of has grown, and kind of proportionately, as we've seen people's rights to statutory advocacy grow, we've tended to see people's access to non-statutory advocacy diminish. And of course, this has then a direct impact on the way that people's voices are heard, the way that we value people's voices, and then absolutely in correlation, the impact that advocacy can have in terms of challenging those closed cultures that they began in. So our statutory advocacy models, you'll all know, I'm sure, we've got independent mental health advocacy for when people are detained in hospitals, and there's some real challenges. We'll come on some of the opportunities for potentially strengthening IMHA services in a minute. But we know there are challenges, particularly for people with a learning disability and autistic people in accessing IMHA services. And we know that IMHA services are often failing people when they could be ensuring that the restrictive practices people were experiencing weren't happening in the same way. So we've got our IMCA services, and they're really specific around decisions around serious medical treatment and long-term accommodation, and so less relevant potentially when we're thinking about closed cultures, although IMCAs will still be coming in and supporting people around decisions about where they may live, and it's those decisions where IMCAs could be having an influence in terms of identifying closed cultures. Care Act advocates obviously are supporting people in their care and support planning, care and support assessments, and care and support reviews, and of course within safeguarding processes. And then paid relevant persons representatives, so while not 100% specifically advocacy, are people who are independent, are representing the person and are going into closed culture settings on an ongoing basis. But what we heard during our review was that access to statutory advocacy alone wasn't enough in terms of enabling people to have a voice that was heard and a voice that mattered, nor was it enough to enable individuals to challenge their experiences of restrictive practice and to challenge closed cultures. And so what we heard very, very strongly was that there is a need for a broader range of advocacy services to be available to people, specifically access to peer advocacy and to self-advocacy groups, to enable people to build those skills and to seek support from peers who are experiencing similar circumstances. Next slide, please. Okay, and actually we'll skip on to the next one again. Thank you. So the Bart's recent report, so Hayley talked about Out of Sight and the Wharton Hall report. So those reports, along with our review of independent advocacy, identified that advocacy isn't always the effective component of safeguarding that it should be and can be. And there are lots of interconnected reasons for this. I think one of the things that really, if you've not yet read the Wharton Hall report, the Wharton Hall report identified that one of the most significant risks is the way that advocacy was commissioned and delivered within that setting kind of created an illusion of advocacy. It kind of provided this false safeguard. We think there's some good advocacy, you know, we've got advocacy services going in, but actually the restrictions and the limitations of that advocacy meant that it wasn't the effective service that it needed to be and didn't play the part that it could have played in preventing the awful things that happen to people in those settings. Next slide, please. Okay, so I'm going to focus really the next little bit of our time together on here and kind of go through some of the findings from our review in relation to advocacy within closed cultures and what we can do to ensure that advocacy is effective. So what we've heard very, very strongly is that people need to be able to access a broader range of advocacy, as I've just said. And there's some real challenges around that in that, you know, we know advocacy services are very stretched. There is an over-reliance on statutory advocacy, but without that broader range, people's advocacy needs are not being met, people's voices aren't being heard, and people aren't able to be included in the way that they want and need. We heard really clearly from people who draw on advocacy and from family members that people want and need access to more holistic and longer term advocacy. The way that our statutory models of advocacy have developed over time means that people can experience kind of short-term episodic advocacy. So that's based on the situation that they're in. You've got a review coming up, so you can have some advocacy for that review. You're detained under the Mental Health Act, so you can have some advocacy to make sure you've understood your rights and to help you kind of talk to folk about your care and treatment. There's a decision being made about your serious medical treatment, so you can have some advocacy then. So advocacies are people's rights to statutory advocacy is defined by those circumstances and the situations that they're experiencing rather than their actual need for advocacy or what's going on in their life more generally. And so we found, particularly for people with a learning disability and autistic people, where it may take a bit longer for people to build a relationship with their advocate, that those kind of cliff edges that they might find themselves, kind of where their eligibility to a particular type of statutory advocacy kind of ended, that their relationship with their advocate also had to end. And particularly when people were being placed a very long way away from home, people's rights to care act advocacy, for instance, you'll all know, I'm sure, is based on where they were from, whereas their Independent Mental Health Act advocate is based on where they were at that moment, the hospital that they were in. So suddenly they might need to have another advocate who didn't know them very well, despite them already having a relationship with somebody else. So there's some real challenges around the way our legislation supports or doesn't support people's access to more holistic advocacy. What people told us really clearly they want and need was one advocate for as long as they possibly could have one that was able to follow them in and out of hospital. And we think that's a really important part of advocates also being able to identify closed cultures, and that the person, they've got a relationship with that person, they understand what that person wants and needs. Excuse me. We had some real challenges about how accessible advocacy was, and that was often to do with the way that advocacy was being commissioned. Excuse me. So, for instance, we found hospital settings and environments where there were multiple providers within one setting. We've heard about kind of national organisations or bigger organisations, advocacy organisations, which kind of had a helpline, which was often a hindrance or a barrier to people being able to get in touch with and access the advocacy organisation. We heard stories of it taking kind of 3 to 6 months sometimes to even identify the right advocacy organisation. So easier to access, more easily available, and those things are all in our gift, really, to start to think about when we're commissioning advocacy. When we're thinking about closed culture specifically, as well as the need for people to be able to build a relationship with their advocate, the advocate to be known, advocates must be present within the settings that they're working in. And we heard from advocates from hospital settings and from people who draw on advocacy that often advocates weren't visible, they weren't known, they didn't have a regular presence. This was exacerbated even further within children's mental health settings. So we know we need advocates to be present, they need to be visible, they need to be known, they need to be able to build a relationship with people. And that sometimes means just being around to have a chat and a cup of tea, rather than being focused on a kind of transactional, helping somebody, I don't know, for instance, helping somebody to prepare for a meeting. So people told us really clearly they need a relationship. And I think somebody else mentioned earlier the importance of trust. And absolutely, we heard the same again in terms of how to create effective advocacy. People need a relationship and trust with that advocate. Advocates need to be supported within their practice, and we heard from kind of Hayley and Stefan earlier, and so all of the things they talked about kind of are relevant really for advocates in terms of maintaining their professional curiosity. Unfortunately, we heard examples and scenarios during our review of where the advocacy service within a closed culture setting became a closed culture in itself. So we had closed culture advocacy within closed culture settings. And we know there are things that we can do to stop that happening and to enable organisations to operate more independently, to maintain their professional curiosity, to ensure they've got their kind of higher standards of understanding human rights and restrictive practice. And some of that is about really knowing and understanding what excellent and good practice looks like, rather than advocates starting to accept that kind of heteronormative, the normative narrative that Alexis was talking about, and starting to believe this myth that this is how people should be being cared for and treated. And that's some of what we started to see with advocates kind of accepting or believing that people needed to be in hospital, that the restrictive practice that they were experiencing was something that had to happen, whereas we know that that's not the case. So really good support to and really enhanced training is one of the recommendations that have come out of the review. So all of that means advocacy needs to be resourced properly and beyond the statutory advocacy that's available. One of the other areas that we highlighted within the review was for the need for advocacy to be commissioned really robustly, and for there to be increased monitoring and oversight of the advocacy offer. That includes kind of CQC's role in understanding how people access advocacy within mental health settings, so and how those mental health settings are supporting and facilitating access to advocacy. We know that advocates need to have much stronger partnerships in order to prevent that isolation that I was referring to, but also to ensure that they keep those fresh eyes, that they develop that really good understanding of what that person wants and needs, and increased oversight and commissioning and delivery of advocacy. Okay, I've got one last slide and then I will finish up because I think we're running a wee bit over. So I just wanted to finish up with this slide, which really emphasises the messages that we heard from people with a learning disability and autistic people alongside their families in terms of what they wanted from the advocacy services that they draw on. And I think when we look at those areas and think about the statutory advocacy that people are able to access, there isn't necessarily the strong correlation that we want to have. And so that hope and aspiration from NDTi and the partners that we work with during this review is that we can start to use these points that people identified that they wanted from their advocacy as a blueprint when kind of designing and commissioning advocacy services. There are a number of other recommendations within the review. I'm not going to talk to them all now, but I encourage you to have a read. Okay, thanks ever so much.
There's a number of resources that have been included that people can read when the slides are shared. Gail didn't speak to all of those slides, but there's information that you can read. I'd now like to introduce Lemia McEwen, who's going to speak about the work that's been going on in Kent County Council in response to closed cultures that have been experienced at Hesley.
Thank you so much, Hilary, and thank you all for allowing me to speak to you today. So my name's Lima McEwen and I'm the Assistant Director for Quality Assurance and Safeguarding for Integrated Children's Services within Kent County Council. And what I'd like to do today is to talk to you about our response to closed cultures, particularly in relation to the Safeguarding Review Panel and the Hesley findings. Next slide, please. So I think when sort of thinking about closed cultures, I think it'd be fair to say that although the concept and the understanding of closed cultures is well known within adult services, it's less well known within statutory children's social work services. So what happened and the devastation that happened in Doncaster in relation to the Hesley findings has really provided a mirror, I think, for us as children's services to kind of really start thinking about closed cultures and reflecting about how our practice may create a barrier potentially to being able to challenge closed cultures. And that's what I really want to kind of highlight that we've been reflecting on and share with you some of our ideas today. So thinking about the Hesley group and what was kind of found in terms of kind of the details of that, I think it's important just to kind of share with you some of those sort of findings. So the Hesley group had 3 residential homes, and they were caring for 108 children. And this was from 55 local authorities. What was found was that these children suffered horrific experiences of harm in terms of being restrained for long periods of time, their cultural and identity needs being abused. So, for example, in one of the homes, some of the children were from Afro-Caribbean heritage and they had their hair shaved. They were completely dehumanised, very much what some of the things that kind of Alexa was sharing with us earlier. And the Safeguarding Review Panel wanted to kind of understand, you know, why did this happen? What was kind of going on? And I think when we sort of talk about plain sight, you know, these children were abused in plain sight, and this was a collective failure across the whole kind of professional partnership. I think, you know, Ofsted had even rated some of Hesley Group's homes as good. So that idea of a collective failure was really the main focus of their initial review. Next slide, please. Thank you. So from the in-depth analysis, what it highlighted was the quality assurance processes that were in place were failing. So there wasn't that professional curiosity, there wasn't that challenge, there wasn't that triangulation. So from a local authority's perspective, we weren't doing enough to understand what was happening for children in terms of the care that they were receiving. There was a delegated responsibility to care providers, and we were overly optimistic. We took what care providers had said they were doing, and we didn't bother to check on that. We didn't bother to ensure that we were getting children's voices, families' voices into that care planning. There was also a lack of triangulation and exploring of patterns from the LADO, so the local authority designated officer, to kind of explore and understand the trends that were sort of coming out in terms of when safeguarding referrals were coming in. Next slide, please. So the initial part of the safeguarding review led to a call to action. So I think the safeguarding panel was so worried about what they'd found in terms of that lack of curiosity and lack of accountability by local authorities for children, that they wanted all local authorities to go out and to ensure that they'd undertaken a thorough review of those children that are in residential facilities, that are also in children's homes, that have complex and profound needs. So our response, Kent's response, was to develop a series of questionnaires to be able to kind of share that with providers, share that with professionals, share that with parents, and try and triangulate that, as well as doing immediate face-to-face visits, observing children, looking at records, tying those in with, for example, Regulation 44 visits, to ensure that we had an accurate understanding of the child's experience in those homes in that moment. Next slide, please. So fortunately, we were able to provide that assurance to the National Safeguarding Panel that the children that we had in residential facilities that were also schools, residential schools, that the care that was being provided to them was good. So having addressed that immediacy, we also wanted to kind of reflect though on what was the kind of barriers, what were the kind of, you know, issues that were sort of making this lack of curiosity and this lack of triangulation so commonplace. Next slide, please. And I think one of the things that we reflected on as a council was the idea of the lived experience versus the living experience, and how actually sometimes when we sort of think about the lived experience, it can make conversations too comfortable. I think through framing experiences in the past, it can sometimes not allow us to think about, actually our role is to think about the living experience of what's going on for that child right now. The idea of the lived experience can often feel sometimes like a political concept, I think, a token term that can be thrown into things, and actually it took away from our responsibility of kind of assessing what's kind of going on for that child now. So we wanted to kind of think about language, and we wanted to kind of think about how language can be a barrier. So that was one of the things that was really important for us to be able to reflect on ourselves. And also, I think it was about sort of thinking about the way that we work in silos as well. So often with statutory children's social work, there is a focus on child protection, there is a focus on child in need, there's a focus on undertaking those statutory roles, and we can often be siloed into that aspect and then think, well, we don't know that much about residential social care. The providers, they're the experts in that, so we can just take what they're saying. And I think that was the kind of mistake that we kind of fell into. So it's about sort of thinking about how do we take that power back? How do we actually hold that mirror to providers? How do we feel confident in kind of challenging what that living experience is for children? So when we're having in our care plan and we're sort of saying, you know, that this child needs to have additional support in terms around independence living skills, or, you know, they're needing a certain level of supervision, they're needing a certain level of kind of support in terms of accessing activities and so on and so forth. How do we see that? How do we get confirmation and get assurance that providers are providing that? So I think what we wanted to do was to really start developing tools for social workers to feel confident in doing that. So one of the things we developed was the purposeful visiting form, and that was a form to support social workers think about prompts and think about things that they could look for when they were doing visits to children in their place of home. We wanted to think about how we can support social workers do that from the moment of now, from that living experience. And so we've been developing a series of videos that we've done with our sort of virtual children in care service to give them a tour of a home, give them that experience of kind of walking through somebody's shoes of day-to-day living, and some of the things they can then kind of use to kind of question, to kind of ask for, so they can feel confident. Next slide, please. I think the other kind of barrier, which kind of relates to the idea of sort of silos, was I think that often social work practice can sort of take things on ourselves, so we can kind of, when things are not quite right, we can put the pressure on ourselves. So one of the things that children in care have is they have an independent reviewing officer, and that reviewing officer should have oversight of a child's care plan and be able to kind of support the progress of that plan and hold the professional network to account. And one of the things that we noted is that the IRO would often put the focus on the social worker. So there's a lot of pressure on the social worker for that child's care plan to progress, for aspects of that child's care plan to be in place. And we wanted to kind of move that responsibility away from purely the social worker. How could we get everybody to be accountable, all the professional network, including health colleagues, the care providers? You know, how could we make sure that responsibility is shared for the particular aspects of the care plan that particular agencies are leading to? And it sounds really obvious now, but actually that was something that we weren't doing. We were putting all the pressure on the social worker to chase up, to deliver. And I think that led to sort of gaps, that led to things necessarily not always being followed up, or social workers knowing exactly how to follow up everything. And so what we did is we moved that away, and we asked IROs to put direct escalations to care providers, to partners. So if the care plan wasn't being met, then we would escalate to that particular professional that's responsible for that aspect of the care plan. And we've sort of moved away from having, you know, we sort of started this in 2022, and we had 335 escalations that were sort of directed at external agencies, and you know, we're now coming up to sort of 700. So we're really embraced that, and we can see that that's making a real difference in creating positive outcomes and kind of holding the whole network to account. Next slide, please. And I think sort of moving on from that, I think sort of thinking about what are our next steps, and we sort of heard just now in terms of sort of thinking about advocacy, and I think within that there is that role of how do we strengthen the role of non-statutory advocacy. How can we demonstrate advocacy in the way that we work with children and families? And for us, that's about how do we strengthen the family. I think we've heard about the expert being the family. How do we support them and being able to kind of challenge closed cultures with us? How do we support social workers take an approach of rights and needs? How do we challenge language? So often, you know, we hear the term so much like complex or trauma informed, but how do we kind of break that down? You know, sometimes it's not about it being a complex case. It's about children having unmet needs and how are those needs being met. When we're talking about communication difficulties, how are we supporting to hear a child's voice in terms of communication? So there's a lot of work that we're doing in terms of sort of thinking about language and how we sort of challenge ourselves in the kind of language that we're using. There's obviously training and development and support for that. So we're working on developing closed cultures programs and online guidance for staff. And as I said, this all sounds very obvious to say, but I think from a sort of children's social work perspective, from a statutory perspective, it's something that has always been connected, but not a central part of our work from a sort of child protection perspective. And that's the thing that we're challenging, we're sort of moving away from now, and we're kind of recognising that actually it's that system approach that's going to protect children, and it's not just a purely social work approach that's going to do that. And also sort of thinking about leadership and sort of thinking about how do we model the practice that we want to see. So there's an expectation now within Kent County Council that all those children that are in residential placements, that are in placements away from home, that are with foster carers, that we as leaders, as senior leaders, go out and we do those visits as well. So we will do those purposeful visiting forms as well. So, you know, every 6 months we'll have a senior leader that kind of supports that approach and kind of demonstrates that. The final kind of area in terms of sort of thinking about how do we challenge closed cultures is very much in terms of thinking about diversity and thinking about inclusion. Next slide, please. So I think one of the things that we've always wanted to kind of recognise is diversity and inclusion, and I think initially the sort of view was it's a golden thread in everything that we do, so we don't need to kind of mention it explicitly. And we've had to kind of reflect on that and say, you know, actually we do need to mention it explicitly. It does need to be a significant you know, central named piece of work that we're doing. And so one of the things that we have been kind of working with in Kent is to work with our principal social worker to look at developing diversity and inclusion plans for each of the areas of social work that we do. So we really set those kind of expectations, and we really kind of set those goals, and it's not something that's a golden thread that can then just merge into general kind of social work practice and potentially be ignored. It's something that needs to be addressed specifically. It's something that we need to feel bold enough to kind of ask providers and to kind of demand that we see how they're meeting children's individual needs. So this last slide really just kind of highlights some of those things that I've just mentioned that we're working on and we're developing. But I think it's addressing our own culture to address others' cultures that we've been able to kind of make the most success. So I think that's it from me. So thank you.
Thank you very much indeed, Lemia. So we're now going to move into the questions time, and we've got about half an hour for some questions. So I'm going to kick it off with some that we've had in the chat. And the first one that we've had quite a few comments in the chat, but by way of a question, there was an early question from Rebecca Fisher at Tees Asconway Valleys Foundation Trust, and she was talking. This is aimed at Stefan in the first instance. But it might be interesting to get Alexis's response as well. As an OT, I'm curious how CQC see feeding cups as restrictive. We often provide adapted cups to individuals to promote independence and support them to engage in this activity rather than requiring support from others. So I thought I would start you off with that, Stefan.
Yeah, thanks, Hilary. And I think it's I couldn't reply to you, sorry, Rebecca, but I think it's actually a really good example to have a conversation about. So when I think about,
excuse me a minute, Stefan, can I just ask Jensen to take the slides down for a moment, and then we'll have the speakers a little bit bigger. Thank you. Do carry on, Stefan.
Okay, sorry, you now have me bigger on your screen. I think it's such a good question and a really good example, because it's actually one that will probably help to really understand how we look at restrictive practices differently. Sometimes we get lost in like a lot of detail, but I always come back to the really simple definition of restrictive practice, which is either making you do something you don't want to do or stopping you from doing something you don't you do want to do. And I think, Rebecca, you are coming at it from the sort of using a tool to promote people's independence. Think about it from a different side. So, Alexis, you talked about, you know, controls being put in place over people. So, if I say everybody in the service that I'm providing has got a learning disability, and just because you have a learning disability, I'm going to put this control in place for you that stops you from using crocky like anybody else does. But just because you have a learning disability, you have to use a bib or a feeding cup. I'm just using a really crude and broad example, but it's hopefully illustrating that rather than thinking of of it as something that is perhaps put in place. So I'm going to think about my sister for a second. So my sister had a neurodisability, and she absolutely didn't want to have bibs on her. So staff did try and do that, and she really didn't want it. So that was for her was really quite restrictive. Actually came up with a different solution, which was a lot different. But rather than everybody being made to wear a bib just because of a condition or a background, actually working with the person to understand what does the person want, doesn't want. That blanket approach, perhaps being quite restrictive, that's a different take on it. So I hope that makes a bit more sense. But yeah, in essence, it's coming back to those controls being put into place for people, not linked to an actual need, perhaps, or like you described, Rebecca, to promote independence. It's really thinking, no, I'm stopping you from doing something like the everyday things that we are like a china mug or cup or a plate. You know, you find in services that there's only plastic cutlery, plastic plates available for everyone, rather than thinking actually how can I support people to live an independent and meaningful life that actually works for the individual. Alexis, I don't know if there's anything you were thinking about this.
No, I think just to say, obviously, where it's used as a blanket restriction is the short answer, which I think you've covered in detail already.
Thank you, Alexis. Yes, it's helpful. Another question, which is a slightly different topic, is from Judith Nichols. So she's prefaced her question with a bit of a paragraph. So she says, there's a very real danger of an increased number of supported living provisions becoming closed cultures, with the focus on hospital discharges in the light of Walton Hall, etc., which rings alarm bells as supported living provisions where the accommodation is the individual's own home is not subject to the same regulation and inspection. CQC inspects supported living providers, but not individuals' own homes when there are significant restrictive practices. Do we have any idea nationally how many individuals may be impacted, especially as not all individuals impacted by restraint or closed cultures may be subject to deprivation of liberty? So it's quite a big question with quite a lot of bits, actually. So we might want to ask Hayley about closed cultures in non-registered settings, although the home care may be and the support may be regulated. There's an issue there. But in terms of any idea nationally how many people may be impacted, I'm not sure if we know. Judith, do you want to come off mute? You've put your hand up. Did you want to add something before they answer?
Yes, thanks, Hilary. It is a real concern for me, and I think for many local authorities and ICBs as well, given sort of sorry, my phone's ringing. It's non-stop. Excuse me. It's the focus on hospital not being the right environment for people, and quite rightly so, and facilitating sort of moves to the community, and it is a growing concern because we do have environments where individuals are impacted by all the various sort of restraint mechanisms that you highlight, Alexis, and I would highly recommend your book as well, by the way. And it sort of is bothering me because I see some of the provisions and they're single occupancy homes where we have staff spaces and safe spaces, just as you highlighted in Stephen's the presentation on Stephen. And CQC have no route in terms of inspection. And my concern is if somebody is in what is billed as a supported living placement, but you are providing 24/7 care, possibly with 3 or 4 members of staff providing that care, and it is so restrictive, does it cease to be a supported living placement, and should it be categorised differently? Should it be categorised as a residential placement? Because a residential placement can have just one person.
Yeah, I think it'd be useful to hear from Hayley, but I think the point you're raising about lots of different settings can have restrictive practices and closed cultures is an absolutely valid one. Hayley, would you like to respond on this? And I would just say that it's not just the CQC responsibility. So I'll come back in after Hayley has talked about it. Go for it, Hayley.
I think I would absolutely recognise what you're saying, really. And it goes back to, you know, that we recognise that a closed culture can happen in any setting. And it's easy for us to think almost like, you know, as, you know, your Winterbourne View kind of setting, you know, as being the type of setting where you'd see this. And I think we are increasingly hearing reports about more people being discharged with, you know, these really quite intensive, you know, packages, you know, of care sort of like put in that, you know, are actually perhaps not. Well, I suppose they bear those inherent risks themselves about just moving kind of like, you know, the way the care was delivered in that, you know, hospital setting into the community setting, which, you know, which is problematic. In terms of our regulation of that is also a little bit problematic too, because how we inspect personal care is based on like this location method, and we can have many different you know, houses kind of like linked under one registration, and it means we don't necessarily go and inspect every single you know, house or home that somebody has, which potentially you know, does leave some gaps around that. I'll let Stefan come in a second, because I think, you know, there's been a lot of work that's been being done around registration and also with the supported you know, living coalition. But I think again, it's something that you know, we all need to be mindful of in terms of how, you know, how kind of like where we are when we're engaging, you know, with people, and having that awareness out there, you know, with everybody about the signs of this. And I do also just want to acknowledge the point too about people who perhaps receive, you know, quite intensive support in the community that doesn't actually fall within regulation at all. Because personal care as a regulated activity is quite specifically defined. So we can have people, you know, we often see it for people with autism or with other mental health needs that might need support, but actually, because that doesn't include personal care, you know, it won't fall under regulation at all. And I think that's long been recognised as a gap that people can fall through.
Stefan, did you want to add anything?
I might have a similar question to you, Hilary. So I'll probably come to you in a second on that, because I think we're all talking about the working together here, aren't we? And I think
Yes, indeed.
Hayley's asked the question. Hayley's answered part of the question, which is actually where does our current regulatory scope finish, and that in itself is a problem, because the personal care definition is so tight. And if we are going with the example of people moving out of hospital after long stays into their own home, as it should be, if it is true supported living, that's a whole nother thing, because, you know, we were asking there, is it residential supported living? And of course, the care and the housing should be strictly separate. It should be someone's home into which a personal care provider delivers the personal care. Let's just stick with that for a second. But if someone moves out of hospital into their own home, which is then supported living, that person might actually be supported by quite a few members of staff. There might be the presence of the use of restrictive practice or even restraint in the person's support, but at this moment in time, that person doesn't necessarily fall into the scope of personal care because of that. There are other activities which couldn't be physical or prompting that would qualify for personal care. So actually, we as a regulator might not have those people in scope, and that's a problem. So who has got the oversight is my question. So actually, yeah. Hilary's, I'm probably going to hand over to you, but for me, colleagues on the call, I'd be actually really interested in how you keep monitoring those as well. So Hilary, that might be what you're coming in.
A couple of comments first that have come in from the chat. Gail has mentioned that people in those situations are also less likely to have access to and rights to advocacy. They may have a right to it, but they may not be able to get access to it. And Melanie Smiles has mentioned about day services and other activities that are not registered, including certain services that may be funded either as a self-funder or if they're using funds from either an individual health budget or a direct payment from council. But what I would say is we can't leave everything to CQC or Ofsted as the inspectors and regulators. And that's why it's so important that commissioners of services and people doing reviews of care and support, so practitioners who are going in, social workers, others who are doing regular visits, GPs doing annual learning disability health checks. There are, district nursing services. There are people, family visiting and others visiting. We need to equip people to recognise and understand restrictive practices so that they can raise that concern with the commissioners if the commissioners or CQC aren't due to be visiting. So that's why Partners in Care and Health at the LGA and ADAS are doing this work on closed cultures and reducing restrictive practice, because we need to draw it to the attention of commissioners who are actually paying for services or have a market shaping duty to ensure that services are available in their patch, even if they're not buying them themselves as a council. So we have a duty to make sure that we're all working on these issues as a whole to ensure good quality services in our local authority area. And that's why LGA has been funded in the Partners in Care and Health team to do this work. I've also got somebody with a hand up. Let me just see. Is this in relation, James Kerrigan, is this in relation to this point?
Is and I just wanted to give the perspective from Kent and Medway if it was helpful on this very point that we've raised, if you wish.
Okay, go for it. And then
so
we'll
this very point came up in a conversation with me. I've been working in, by the way, Jimmy Kerrigan is my name. I'm the Associate Director for Learning Disability and Autism with Kent and Medway ICB. So, and I've been working on the LDA program for many years here in Kent. This issue came up for me and in a conversation I had with a colleague a few years ago, and what came out of it was we thought and we said that the next Winterbourne View will be in the community, and we could see that happening. So the approach that we've taken on the 29th of November just gone, we held a summit of senior managers within the system to talk about that very thing. No more and no grander than that, but to just begin the conversation that we acknowledge this very risk. And our approach to it is, and the conversation that we've had and that we are taking forward is the solution to it is to very much see ourselves as a system, and so the solution to that is systemic. We and moving away from the silo cultures that we all have retreated into because things are very, very difficult. We've got to come out of the silos and share the problem. And interestingly as well, we didn't think that CQC were a big player in addressing this. We felt that as a system, if we could really create the identity as a system and then really own the risk of that and find the solutions to it as a system. And when we say a system, we mean the social care market who are providing the support, everything up to commissioners, social care commissioners, community learning disability teams and their provider organizations. Between all of us, we have the solution. And so the first thing was that we're taking forward is the real momentum about let's create the system and therefore let's prevent this potential Winterbourne View from happening in Kent and Medway by creating a sort of a systemic solution sort of thing. So that's just a thing. And I suppose my push would be is that the first thing that needs to happen to address this is that areas and ICB areas, ICS areas, you need to have the conversation about it, what it means in your own area to come up with the solutions for it. But that's our contribution to it.
Thank you. I'm going to come back to some of the comments in the chat now. Some of these aren't questions, but I'm just going to rehearse them in case people haven't spotted them while they're listening to the speakers. So Mark Humble has mentioned that he'd be keen to see a document that's accessible for people who draw on services and their families that sets out how they can tell what a closed culture is, and thinking about the top 10 things to look for. And just to let people know that the Partners in Care and Health are going to do some work, hopefully in the new year, with Learning Disability England to look at co-producing some tools on that.
Just say, Hilary,
Alexis, Yes,
That's
Ken.
what we created. If you and just to inform the document you're doing. So
Yes.
if people want an accessible version for,
we've got one from you already. Maybe we don't need to double do.
QR code that I signposted people to. So it really is about identifying restrictive practices so that people actually know what this phenomena is.
That's really helpful. Thank you, Alexis. And I think that the interplay between the restrictive practice and also what a closed culture is quite important to sort of work through. And something that Hayley has mentioned separately and Stefan referred to today is the importance of speaking up. So that's the importance of not just people who draw on services and their families having the confidence and the bravery to speak up when they might be frightened that they'll get punished for it, but also staff who work in services. And Lindsay Cook has mentioned in the chat that it was interesting that the whistleblower in Blackpool yesterday was a student nurse who recognised the negative / harmful culture. I didn't hear about that. I don't know if Lindsay is wanting to come off mute and just refer to that so people know what she's referring to. Are you there, Lindsay?
I am, yeah. It was just the news footage about the court case in Blackpool where the nurses had been over medicating people over a continued period of time and arrived at court to defend that practice as being perfectly acceptable was the comment that there was. But the whistle had been blown initially by a student nurse who had observed these practices.
Thank you. That's really helpful. And was that younger adults, or was it people with dementia, or what sort of setting was it?
Older adults, I believe,
Okay.
people with dementia.
Okay, I'll look that up as well because it's it sounds like that's useful case law to be looking at.
Yeah. A
stroke unit somebody's put in. Thank you very much, Ian. Okay, so further comments down the chat. We've got Mark's made the point about language and that when we reduce people to initials like ASD or LDA, that there is a very clear risk that for our own convenience, and I'm conscious of having to write out my job title as somebody working in the team that supports councils with services for people with a learning disability and autistic people. It takes quite a long time to say it, let alone write it down, but it says what it is on the tin. And the minute we start using abbreviations, we may lose some of that. And so I'm sort of constantly being reminded to get rid of acronyms, 3-letter acronyms or more in documents and so on, so that we can be more clear in what we write and less dehumanizing. Further comments down the chat, we have from Marie Sinclair saying that it's worrying that this goes on in care provision where staff claim they are acting out of a duty of care, and a lot of scrutiny and re-education is needed. And Rebecca Fisher has mentioned that an important and pressing point as a clinician, which she thinks is often forgotten by external stakeholders driven by figures and deadlines and so on, is it goes against that demonstrating loyalty can go against person-centered care. So Rebecca, I don't know if you had a particular experience of that you wanted to explain. Is that loyalty to colleagues so that you make excuses for restrictive practices, or you don't expose them? What were you thinking?
No, sorry, I might not have worded that very well.
Just trying to understand your point.
No,
yes.
It was from Alexis's presentation about our loyalty to obviously the people that we work with and care for.
Right.
And my experiences is that, you know, I work with people with learning disabilities who've got, you know, some very complex needs, and it takes time to build that therapeutic relationship with them and to do the work, and these people need our time, and then we get pressures put on us from external stakeholders when we've got you know, quite complex cases where there's maybe legal systems involved, a lot of different providers around when is your assessment going to be done, when are things going to be done, and we're working with people, we're not working, you know,
right,
we're not
and
so I meant it like that, in that I think that, you know, first and foremost, my loyalty is to my patients, to my service users. It's
okay,
in that sense, but then it's obviously all these other pressures, and I think that loyalty then gets forgotten because we've got so much of the pressures put on us. So I might not have worded it right, but I meant the loyalty.
You have now. You have
Yeah,
now.
thank
Thank you for
you.
that.
No worries.
Is there any response from anybody who's been a speaker today that anybody wants to come back on that, or shall we move on to the next point? Stefan?
Not strictly linked to this, but I just wanted to sort of echo some comments around actually, we've talked a lot about dehumanizing in this context. And I think this, if you want to take something away from all the speakers today, is actually start thinking from the person's point of view again.
Yeah.
You know, we're talking about acronyms, you know, I'm not an acronym, I am a person. I'm not a complex need. I am a person who requires different types of support so I can live the life that I deserve and have the quality of life I need. And I think we talked about not focusing on behavior, because actually it's not behavior, it's how I communicate what I need, my emotions, or if I'm in distress. And I think colleagues on the call, you've heard it from different speakers. I think listening to people and actually understanding people as a unique individual is a really good starting point to help reduce restrictive practice in closed cultures. What's the person telling you? Find out from their point of view.
Thank you. Yes, that's really important. There's a comment from Maria Sinclair, who has said that as a commissioning team, we've come across worrying traits of closed cultures within settings, and it's very hard to break this behaviour, particularly if it's been long-standing. One of the things I would say is that there's some work that's been done by, I think it's Skills for Care, that we refer to in the resources we're due to publish, that is training specifically to providers to help them think about how to develop positive cultures, because you're right, cultural norms and custom and practice can really sort of be very insidious, and it's very difficult to break that. But the first thing to do is to recognise that there may be a risk of a closed culture developing, and then being able to do something. If you don't even recognise it, or there's no external visitors coming in, so nobody's even looking at it to recognise it, then there may be some difficulty to start working on putting it right. So I think the education that was mentioned already is really important, so that all of us who are involved in assessing needs and commissioning services, either at a strategic level or an individual level, need to recognise what closed cultures are and what restrictive practice is, in order to be able to then work to develop the positive cultures that will prevent those things happening. And it's been said already quite a lot that involves a lot of us. So it's not just down to CQC coming in when they inspect, it's also down to anybody that visits, and trying to make sure we equip everybody, including the people who draw on services and may be experiencing some of those negative and poor care things, that they're equipped to speak up, but also everybody else is equipped to recognise it and to speak up about it, and not to fear responses that might come after that, as we've heard of in the past with some of the colleagues who've been whistleblowers. So there's a few comments further on about the liberty protection safeguards and doles and community doles in the context of ordinary living and living in ordinary housing. We know that LPS has been delayed, but there's still a lot of scope in what is available at the moment in terms of doles in care homes and hospitals, and community doles for people who are not in care homes and hospitals. And I would encourage people to apply for community dole when you think that it may be going on. I think that there are probably lots of situations in settings that are other than care homes and hospitals where people haven't realised that they should be applying for authorisation for a deprivation of liberty, and we need to be applying the acid test in those situations and checking out whether the court should be applied to, and that applies with under 18s as well as over 18s, although the liberty protection safeguards applied to 16 and above. There are frameworks for children's services as well that enable an application for authorisation that might need to be taken forward, and that enables safeguards to be put in play. Okay, I'm conscious of time. I'm minded to finish there, unless there's any pressing question. I think we're probably at the end. We've just got a comment from John Kelly that is telling us that Skills for Care are holding a roadshow in March for the Northwest, exactly on the topic of building positive culture. So that's useful. It'll be interesting to see whether that's replicated elsewhere. Perhaps John can keep us informed and we can send out information when, if there's any more information. Thank you for that, John. So just to finish off, if you could pop the slides up again. I think we're at slide 64, Jensen. And I'll just say that we've got two resources that are going through the sort of final stages at the moment. One is about guidance on closed cultures and questions to ask. So that's looking at the whole commissioning cycle and thinking about questions you might ask when you're developing your spec, questions you might ask when you're inviting and evaluating tenders, and also questions you might ask when you're visiting. And that's aimed at commissioners and contract compliance staff, but also questions that you might ask or information you might triangulate. I think Lemia was using that term from other sources of information. So that might include social workers, safeguarding concerns, complaints, people who are undertaking clinical reviews and so on might feed information through, and thinking about how you liaise as commissioners in social care with commissioners in health, education and CQC to share intelligence, to make sure that you're working together to improve the quality of services and improve on closed cultures. The other resource is a resource, again, for commissioners, although it may be useful for others as well, which is a sort of essentials for commissioners who are commissioning support for people with a learning disability and autistic people, to understand what is required of providers in terms of commissioning training for reducing restrictive practices, and also to be clear about the CQC policy position statement that was published in Rebecca Bowers' blog in August. So some of what you've heard today is built into that reducing restrictive practice resource as well.